Right, welcome to everybody. My name is Peter Holton, and I am the Training and Engagement Officer for Northern England with Glaucoma UK. Our speaker this evening is Neeru Vallabh, and she's a consultant ophthalmologist and senior clinical lecturer at Liverpool University Hospital Foundation Trust and University of Liverpool. I'm so glad that you've all been able to join us and rejoin us if you have, to spend your evening with us. And I'm just going to spend a few minutes talking about the format of today's talk and a little bit about Zoom. There will be 2 short polls launched during the webinar, and they're to help us see the difference the sessions are having. I'm going to launch the first one now, and this will stay on for a few moments. So if you bear with me. Okay, I've just launched the poll there. So if you take your time and fill that in, please, that would be great. And once Neeru has finished speaking and given her fabulous presentation, we'll have a question and answer session. So please remember to post any questions for her in the Q&A box. And don't forget to like questions that others have asked. That will make them more popular. And if you're watching on Facebook, welcome. Please comment on the feed and your question will be fed into the webinar. Please be aware that if you are using captions on Zoom, they may not be accurately translated. And don't forget to post the questions in the Q&A. So now I will hand you over to Neeru, and thank you very much, Neeru.
Great, thank you. I'll just double check this looks okay. Oops, sorry. Okay, great. Is that okay?
Yes.
Great, okay. Thank you. So thank you very much for inviting me to speak today. So today I'll be talking about Preserflo and trabeculectomy procedures for glaucoma. So firstly, I think it's important to recap what glaucoma is, because some of you may be very early in that journey and some of you may be experts in the field. So I will just give you a brief overview of what the condition is. So glaucoma is a condition of the eye where there are changes to the nerve at the back of the eye. So the nerve is the part of the eye which allows you to see. So in glaucoma, you find that it's usually a chronic progressive condition, and it can be associated with aging, but can also run in families. But it can occur suddenly in some and can get much worse rapidly in certain individuals also. So on this slide here, I've got a few images. The first image on the top left-hand corner shows a healthy optic nerve, which is a round circular shape with a small central depression, which is what we call a cup. So you may hear your consultants talking about your cup to disc ratio or cupping. So essentially, when the nerve is healthy, the wall of the cup is much thicker. So it's more like a donut in a sense. Whereas in glaucoma, we see that the central depression or the cup increases in size compared to the outer rim, so that the walls of the cup become thinner and are similar to a cup or a mug. So that's the image on the top right of this screen. So essentially, what do these changes in the back of the eye result in? They can cause loss of vision. So you may not know that you have glaucoma until you have loss of vision, which then affects your central vision. And that's because you may not have any early warning signs because it's affecting your peripheral area of your visual field. And also because you'll be using 2 eyes together, you may not be aware that certain areas are missing from 1 eye. So the way we test this in the clinic is we use what's called a visual field test. Essentially, you sit in a large instrument, a bit like a fishbowl, and you press a button every time you see a light. And that allows us to map out areas of your vision that are missing or affected. So in the bottom left of my slide, I've got an image of a healthy visual field, which essentially has a light grey shading. Whereas in glaucoma, what you find is that you have areas of the vision that are missing. And so on the visual field test, the image on the right-hand side, you can see that there's a black area in the top of the peripheral vision. and that represents the area which is affected. Oh, apologies. So essentially with glaucoma, you may not be aware that that area is missing because you're using your central vision all of the time. And this is just demonstrated further in this image on the right-hand side. So you have areas, the top left image shows a street view, and essentially you can see all of the cars and you can see the buildings on the left-hand side. But with glaucoma, it could present in different ways. It could be that it's like a black tunnel around and you can only see the center. It may be that the tunnel, the surrounding of the tunnel is blurred. It may be that you see black patches, or you may just see blurred patches within your vision. Or it may just be that when you're looking out at the street, you may not see one of the cars that are there or one of the doors that are there, for example. So how do we treat glaucoma? Well, firstly, the main risk factor for developing the condition is an increased pressure in the eye. The rise in pressure in the eye causes damage to the nerve at the back of the eye as it presses on the nerve. So my first image shows a picture of an eye, and it shows arrows inside it. And these arrows are just representing the pressure and the tension that this increasing pressure in the eye is having on the back of the eye, on the nerve and the blood vessels there. So lots of research has shown that by lowering the pressure in the eye, this is the only confirmed way to treat the condition at this current time. So why does this pressure build up? It's because of a misbalance between the production of the eye's own natural fluid, which we call aqueous, and drainage of this natural fluid. So the image on the right-hand side here shows the front segments and structures in the eye. So the natural drain in the eye is called the trabecular meshwork, which is a sieve-like structure and has multiple little pores. But as we get older, and also in glaucoma, this drain becomes poorer at draining. It's almost like there are leaves within the drain and it doesn't work as well. So as a result, the eye becomes more tense. And in your clinic, you might find your doctor refers to your eye pressure as something called intraocular pressure, or they call it IOP for short. Essentially, the way that we measure the pressure is using a unit called millimeters of mercury. And the normal range of pressure is from 10 to 21. But many glaucoma patients may present with high pressures in most cases. Some present with normal pressures. But either way, what we know is that the research has shown by lowering the pressure, that's the best way to treat the condition. And the way we lower the pressure is done with either drops or laser or sometimes surgery. So the drops that we use typically either reduce the production of fluid or try to increase the outflow of fluid. But unfortunately, all of these treatments cannot restore the vision that has been affected as a result of glaucoma. The main aim of the treatment is to reduce the pressure and prevent or slow down any further damage to the optic nerve and to protect the vision from getting worse. So my next slide shows a side profile drawing of a trabeculectomy operation. And this is the image that's found on the Glaucoma UK website. A trabeculectomy is an operation which creates an alternative drainage channel to help the draining of the natural fluid in the front of the eye. And this is done through an alternative passage. This operation creates a bypass for the blocked natural drain of the eye, and this is done through a hole that is created surgically, which we call an ostium. This is underneath a flap, and your eye pressure is reduced because the fluid can now drain more easily through this newly created drainage channel, and it creates a raised area or a reservoir called a bleb. So this bleb-like structure that we create is at the top of the eye, and it's underneath the top eyelid. The bleb is then naturally absorbed by the body. But there are certain factors that can reduce the success of trabeculectomy surgery, and these include if you're younger, because you can be more prone to developing scarring. Certain ethnic groups may not respond as well as others. If you have other conditions like uveitis, where you get inflammation in the eye, or if you've had previous eye surgery or eye injuries, if you have lots of new blood vessels growing in the front chamber of the eye, and also natural healing processes and natural scarring that we develop can cause the surgery to fail. If you're diabetic, or certain eye drops or multiple use of eye drops can also result in some failure. So this image here on the next slide is called an anterior segment optical coherence tomography scan, which shortens to anterior segment OCT. This is a technique that we're now starting to use in clinic, which uses light waves to create a cross-sectional image of the front portion of the eye. So on this image, it shows a scan through a trabeculectomy site, and this has got labeled areas of the image, which has been created by one of my optometrists called Matthew Roney, who works with me in Liverpool, as at present we're doing some research into using this new imaging technique to understand what happens after trabeculectomy surgery. But if you were to look at the trabeculectomy from using your eye by getting the patient to firstly look down, this is what the trabeculectomy surgery site looks like. So the first image on the left-hand side shows a mild swelling of the white of the eye at the top of the eye, which is called a bleb. So this is described in this way. By looking at this image, you'd say that it just looks like it's a little bit swollen diffusely in that area, and we describe that as a low-lying bleb. But the key thing is that the patient is looking down. So this isn't seen when you're looking at the patient when they're looking directly at you. Sometimes we can find that the bleb is more well-defined and a little bit more raised. And so this is the image on the top right-hand side. But looking at the images at the bottom right, you can see that the first image, the eye looks quite red over this bleb area. And that's because that's very early after surgery, because you'll get all of the blood vessels around the area being engorged and a little bit of swelling and redness. That's perfectly normal. But with treatment with some steroids over time, what you'll find is that this becomes whiter, and you'll then have this remaining swelling or bleb that persists afterwards. So what is Preserflo microshunt surgery? So this is the next image. And this shows that this is a new device, which is an 8mm long tube, which is inserted into the eye to lower the pressure in glaucoma and also reduce the need for medication. So this image shows how it sits in the eye, whereby one end of the tube sits in the front chamber and the remainder comes out and also creates a fluid-filled space called the bleb again at the top of the eye. The tube itself has a small 1mm fin-like shape in the center. Well, I shouldn't say center, actually, it's more 1/3 into the device. And that basically helps to allow the device to remain in place and sit in the pocket that the surgeon creates. This device is made up of a novel synthetic material, which is called SIBS, but the long fancy name is polystyrene block isobutylene block styrene, or SIBS essentially. But it's been safely used as a cardiac stent coating for over 15 years. So the diagram shows the dimensions of this, including the outer diameter of the tube, which is only 0.35 millimeters, and the inside of the tube itself, the functioning part, is only 0.07 millimeters. So it's very, very small. In the past, this was called the in-focus microshunt, but the newer name now is the Preserflo microshunt. So you might find that some people have referred to it with different names, but that's because of different acquisitions of the device by a company, and they've changed the name essentially. But the idea of this device is that rather than creating a hole for the fluid to drain through, it uses this tube that creates the drainage. But the reassuring thing is, because it's been used for such a long period of time, it's deemed to be safe. It won't cause an allergic reaction, and it won't be rejected by the body, and it won't disappear or disintegrate with time. And it's also not metallic, so it's perfectly safe, for example, for X-rays or MRIs. So this next image is again using that anterior segment OCT scanning technique, which I described earlier. And it provides a cross-section through the profile of the Preserflo microshunt, where you can see one side of it has the bleb, which is the fluid-filled spaces, and the other side is sitting in the front chamber of the eye. So that allows continuous drainage through that tube, the Preserflo microshunt, creating that bleb and allowing that drainage there. So this next slide shows how the eye appears to the naked eye if you were looking at the patient. So if you were looking straight ahead and you just lifted the eyelid slightly, the first image shows that there's just a very small tube-like thing that can be seen at the top of the eye, in front of the colored part of the eye. So the second image shows this with a much more zoomed-in view. And so there you can just appreciate that it's just at the top of the eye, there's a little small tube that you can see, and that's where it's draining. And the third image shows the patient looking down, Again, this is early after surgery, so it's a little bit red at this stage, but you can see that there is, again, a fluid-filled space, a little swelling at the top, and that's where this natural fluid is draining, and that's where it's causing the pressure to reduce by using that route. So what I thought I would do is talk about what it's like from a patient's point of view when they attend for surgery. And actually, these are quite similar, and I will go on to talk about the differences in a short while. But on the day prior to the surgery, in fact, you might be advised to stop certain medications, for example, blood thinners, and the protocols for which ones to stop and how to stop them differ from different hospitals. So that will just be clarified with you by the preoperative team prior to attending for surgery. So when you first attend on the day of surgery, you would be booked in and admitted by the nurses. So they would do things like checking your identity, checking your observations, like your blood pressure, your heart rate, checking that nothing has changed since your prior visit, and to discuss the initial day of the surgery and how things are going to proceed with the day. So usually you'll attend either for a morning or an afternoon. Prior to the surgery itself, you will have discussed with your surgeon whether you're going to have it under a local anaesthetic, whereby we numb the eye and you stay awake, or under general anaesthetic, where we put you to sleep so that you're not able to be aware of anything that's going on at the time. And if you come in for that, you usually will have to stay in for a little bit longer for the recovery on that actual day. You'll then have consent, which is confirmed with you either by your surgeon or one of their team. Essentially, they will either go through your consent form and talk about the risks and benefits. They'll put a mark above the eye, and certain surgeons may give you drops prior to the surgery. Some people use these, some don't, and again, that may vary for differing sites. You'll then have multiple identity checks in the anaesthetic room and throughout your journey through the day. So that can be a bit disconcerting because you'll feel like you keep having to repeat your name and your date of birth and details, but that's all very important, crucial measures to ensure that all the team along the way know who the patient is and who you are, and are happy that the right procedure is being performed for the right person. So I know it can be a bit alarming, but that's perfectly normal. You'll then have a drape that's placed over the eye after you've had some anaesthetic. So the anaesthetic will initially be some drops, and then you will have an injection to numb the eye. That is probably one of the worst bits because it will sting, and it'll also affect your vision in that eye, but that's perfectly normal. And after that, it should be nice and comfortable. If it's not, it's important to highlight it to the team that the eye's not feeling comfortable and they can top up the anaesthetic for you. You'll then have a drape placed over the eye in order to ensure that you can't see anything from the other eye, because that's something people worry about, is can I see the operation? By having that drape over the other eye, you're not able to see. And it also keeps the area clean and sterile. So that's perfectly normal. If you feel that you're claustrophobic and wouldn't like to be under a drape, also highlight that to the team in advance so that they can make adjustments accordingly. You'll have a speculum, which is like a clip to hold the eyelids open so that we can ensure that the eye is stable and that you're not able to squeeze or blink or worry about blinking the other eye throughout. So that stabilizes the eye. You'll then have the procedure, which I'll go on to shortly. And then at the end, you'll have a plastic shield and sometimes a swab popped over the eye. And then you'll go home later on after you've gone round back to the main ward and they're happy that you're safe to go home. Usually we stop all drops, all the glaucoma drops, unless there's anything untoward, then you may be advised to continue one or two perhaps. And then afterwards we give you antibiotics and steroids, which is perfectly normal in order to prevent infection and also to reduce inflammation after the surgery. So what are the benefits of Preserflo and trabeculectomy? These procedures are both performed to lower the intraocular pressure in the eye and to also reduce the rate of glaucoma progression. So again, this is just an image showing how the fluid is produced in the front of the eye by a structure called the ciliary body. This then comes up in front over the iris, which is the colored part of the eye, and then it creates a little pocket called the bleb at the front of the eye, through which the fluid drains, and then that helps to lower the pressure. So both of these techniques are using this drainage into this subconjunctival space, we call it, and this creates a bleb. An important thing that I always get asked is, will I have more tears, or will the water come out through the front of the eye? It doesn't, because it's in this covered space. So it's not going to come out as excess watering or in that sense. Your eye will naturally water after the surgery, especially early within the recovery, because of the stitches and having had the procedure. But in the long term, that extra fluid that's draining out doesn't come out in tears. So not to worry that won't be the case. And what are the risks of associated with trabeculectomy and with Preserflo surgery? So as with any surgery, there is a potential for complications or problems to arise. And these can either occur during the surgery, shortly after the surgery, or many months after the surgery. These can include bleeding inside or in or around the eye. There could be a risk of infection inside the eye itself. After the operation, the pressure may be too low or too high, and sometimes that might require additional treatment, either in the outpatient clinic, for example, drops, or sometimes you may need to have some adjustments done in clinic or further treatments, or sometimes you have to have further surgery if the pressure isn't well controlled after having had the procedure. Sometimes there can be inflammation inside the eye, and again, this would be treated with eye drops. Some patients are aware of having this elevated area underneath the eyelid, and that can sometimes cause a slight drooping of the lid. This usually eases over time as the eye swelling eases and as the eye recovers, but sometimes there can be a slightly lower position of the eyelid on one side compared to the other. And it can also cause a change in your glasses prescription. The worst case scenario is sight loss, a 1 in 1,000 chance, if there was either a severe infection or a severe amount of bleeding in the eye which couldn't be resolved. So it's never the nice part, but obviously we have to make you aware of these complications and these risks. So here's the key slide in a sense. How do these two procedures differ? So firstly, when were they developed? In 1968, Kearns first developed the trabeculectomy, and this technique was then modified in 1970 to the technique that's used today. So that's a key difference, because obviously we've been doing that for a lot longer, and we have a lot longer follow-up for those patients, and we're aware of what happens for potentially up to 30 to 20 years in some cases. Whereas the Preserflo was approved and received a CE mark in 2012 and then started being used after 2013. So it's just natural that we obviously have much more years of experience with a trabeculectomy, and we are aware of what happens further down the line than Preserflo. And obviously it's difficult, because when you see new innovation, we can't help but be sure of how these things will be in the long term. In terms of the duration of the surgery, a trabeculectomy can vary from 45 minutes up to 120 minutes. It's not usually as long as that, but in some cases it can take time to stabilize the eye and take those extra measures to ensure that it's performed safely. A Preserflo surgery can take anywhere between 15 to 40 minutes. So it's obviously a lot shorter a procedure from a patient perspective. And so that's the length of time from your point of view that you will be there with that drape and with that clip in the eye. And what about the post-operative visits? So some surgeons may vary, but typically we see you about 1 day after the surgery. But everyone is usually seen at 1 week as a minimum for both cases. But with a trabeculectomy, we can see you up to weekly for 6 weeks. And the reason why that is because the key thing with a trabeculectomy is it can be adjustable in those early periods. So it can be that we find there's stitches that can be removed. There can be a little bit of, we call it massage, essentially, to try and encourage fluid drainage. Sometimes you may need a procedure called needling. So what happens is that when you're in the clinic, we put a numbing drop in the eye, and we use a little needle to try and break away any of the early scar tissue that's forming. It sounds a bit disconcerting, but obviously we make sure that the eye is quite nice and numb, and that can sting a bit, unfortunately, but that is a good way to break down any of that early scar tissue. So for that reason, you need to be seen very frequently for that period of time. And it's also a matter of whether you're comfortable having those sort of procedures done in clinic, and some people that would be extremely difficult compared to others. You are then always seen at about the 4 to 6 week mark in the Preserflo cases, and all patients will then be seen around 3 months and then at 6 months. So with a trabeculectomy, there is no implant that's remaining, whereas with the Preserflo, there is the SIBS material device that's implanted. And what about stitches? So in trabeculectomy, you can have anywhere from about five stitches to 9 stitches, whereas with the Preserflo, it's fewer stitches, so 3 to 5. From your point of view, having stitches in, they will feel similar. So it's usually a feeling of having a lash within the eye, or multiple lashes, I should say, obviously. But these stitches will all be either removed or trimmed by about 8 weeks or to 10 weeks at the latest. So they won't remain in place long term, the ones that are more superficial. Some of the ones that are deeper may remain ongoing. And that's perfectly normal and perfectly safe. But your surgeon will obviously remove that depending on when the appropriate time is. And both types of procedures have anti-scarring medication. So these are called antimetabolites, and they're medications that help to prevent scar tissue from forming. They can either be called mitomycin C or 5-fluorouracil. Typically, most people use mitomycin C, but in clinic, sometimes 5-fluorouracil is used when we do the needling procedures. But these basically help to prevent the scar tissue from forming. So how well do these procedures work in terms of intraocular pressure? So what I thought I would do is I would report some of the recent data that was published by multiple groups, actually, internationally. So it was a study that was done at multiple sites, including the United States of America and in Europe. There were 29 sites in total, including Moorfields, in terms of the UK site. And they provided data on 2-year results where they looked at trabeculectomy and the Preserflo microshunt in patients with glaucoma. So this is a picture of a graph showing the pressure profile for patients who've had both procedures after surgery. So the lighter grey showing the trabeculectomy surgery and the darker black line being the microshunt. So they both start at a similar starting pressure prior to the operation of about 21 millimeters of mercury. So that may not sound high, but you have to recall that patients would be on medications with those sort of pressures. Whereas at 24 months after the surgery, we find that the microshunt group, the average pressure was 13.9, whereas in the trabeculectomy group, the average pressure was 10.7. So you can see that a bit lower. And when you talk about the numbers of patients in this study, there were 395 patients that had the microshunt procedure compared to 130 that had the trabeculectomy surgery. And the longest data that is available for the Preserflo is 5 years in one study. And this was in a group of 23 patients who were treated in the Dominican Republic. This showed an average reduction of pressure from 23.8 prior to surgery to 12.4 millimeters of mercury at 5 years. But just to recall, this is in only a small group of patients. A really great study, which I think we consider in the UK, is the 21st, it's called the Trabeculectomy in the 21st Century, and that was published in 2013. That was a great study because it looked at a total of 428 surgeries that were performed throughout the UK in multiple sites, including Portsmouth, Birmingham, Norwich, Cheltenham, Moorfields, and Southampton. And the mean pressure was found to decrease from 23 prior to surgery down to about 12.4 at 2 years, and again around 11 at the 3-year mark. So we know that the trabeculectomy surgery can typically get your pressure down to a low level and works consistently well in multiple different centers. So like we said, we can see that it works well to treat glaucoma with the Preserflo. Although there's this one longer study, we don't have longer studies yet at this time. And how well do they work in terms of the number of medications? So this multi-center study that I was talking about earlier, they looked at the average number of medications that reduced. So these just show two graphs from the study itself, but just to explain the key findings, with the microshunt group, the number of medications reduced down from an average of 3.1 to 0.9 medications. So when I say the number of medications, that's a number of different types of bottles. So some of the drop medication may have one or two medications within them. Whereas in the trabeculectomy group, this reduced down from 2.9 to 0.4 numbers of medications. And how well do they work in terms of post-surgery procedures? So needling was needed in 24.8% of the Preserflo microshunt surgeries, and this was compared to 9.1% of the trabeculectomy surgeries. Drops had to be restarted in half of the Preserflo patients compared to 39.4% of the trabeculectomy patients. And further operations for either complications or if the pressures weren't quite low enough were more frequent in the Preserflo group of 18.7% compared to 10.6%. And when I'm talking about further procedures, this may, for example, mean a Preserflo patient that then had to have a trabeculectomy, or if a patient had to have a glaucoma drainage tube surgery, if they had to have revision of that bleb site, or if they had to have their Preserflo repositioned, for example. And how well do they work in terms of complications? So what are the differences between the two? It found that there were more frequent episodes of the pressure being too low in the trabeculectomy group, so 51%, compared to the Preserflo group being 30.9%, and that was at any period within the 2 years of that patient. The other complications were comparable between the two groups. What the group have now concluded is that perhaps this was because the anti-scarring medication that was used during the Preserflo surgeries was lower than what is used for trabeculectomy surgery. And actually that has now helping to inform our practice to try and use stronger amounts of anti-scarring medication to ensure that we are able to allow the Preserflo to work as effectively as possible. But as you can see from these studies, the trabeculectomy gets your pressure lower, but then there's also the risk of the pressure being lower still than desired in the trabeculectomy group. So in conclusion, the Preserflo is more novel, so we don't have any long-term data available yet. It has got a shorter surgical time, it has a quicker recovery after the procedure. You don't need as many post-surgery visits for the Preserflo either, and you're not likely to need as many procedures in the clinic, for example, removing of all of those stitches. The pressures are not as low as trabeculectomy, but this may be because of the anti-scarring dose that's used. The Preserflo procedure itself uses an implant, whereas a trabeculectomy doesn't. But the important thing is that you need to discuss with your surgeon what's right for you, and this could be based on the pressure that you need. So some people need a really low pressure. In those cases, probably a trabeculectomy is more desirable. For example, if they started off as having normal pressures in the first place, you're more likely to require, or it may be more beneficial to have a trabeculectomy than a Preserflo. It may also depend on the severity of your glaucoma or how suitable you are for surgery. So for example, if you have difficulty lying flat for a prolonged period, or then having a longer operation may not be ideal for you. It also depends on post-operatively how you're going to recover and how easily you can be seen regularly, as to whether a Preserflo might be better because you don't have to come in as often. So these are all differing considerations as to which one may be more ideal for you. So with that, I just want to say, sort of as it being the end of the year, a Merry Christmas and a Happy New Year to all the viewers. This is a picture here of Michelle Walsh and Catherine Mulhern, who are two of our glaucoma nurses, and that's me and Hussam Muntasir, where we had a stand for World Glaucoma Week earlier in this year. Thank you very much. So I'm happy to take some questions. I'll stop sharing. Oh, you're muted, sorry.
Thank you very much, Neeru. That was absolutely fantastic. I've never heard so many long words, one after the other, all pronounced so very well. We've got quite a few questions to get through. We're not going to get through them all. We will do our best. So the first one, Neeru, I had a trabeculectomy and needling at Liverpool. Worst bit was the drape during COVID, as found it difficult to breathe. Second time they gave me a sedative and I was more prepared. Anyway, this was around 18 months ago. So far, so good. All I've not been seen for a year as my appointment that was cancelled. Local optician says pressures are okay, normal tension. It's not really a question, is it? She's just
No, but thanks. No, it's useful to know, and just to say that if opticians take pressures, if they send that into hospitals, it's always useful to feed into our knowledge and just to reassure that the pressures have also been measured as being okay. But obviously, if appointments are cancelled, it's important to try and get back in touch. And I'm sorry to hear that that's happened as well.
Thank you. Next question. When I had my Preserflo surgery privately about a year ago, I was told by my insurer that the procedure is not approved by NICE because of lack of clinical trial evidence on the longer term effectiveness. They would have been happier about a traditional shunt. Is this still the case? If it is not NICE approved, can hospitals nevertheless carry out the procedure?
Yeah, so yeah, that's an interesting case, interesting question. So NICE will meet regularly and try and approve and consider newer therapies and interventions. But with increasing data, they then will change their guidelines about what can be done. And the key thing is that they are a guideline, but I think when it comes to private insurance, they may have more stringent requirements of what can be used, but just to be rest assured that it is being used throughout the NHS in multiple different sites, and we are having good outcomes. But I can't be sure about different private insurers as to why I wasn't aware that they've actually quoted that they want NICE approval for that. But I'm not personally doing a lot of private work at the moment just because of my other commitments. But yeah, it is being performed throughout the NHS, and I use it for my patients regularly as well.
Great. Thank you, Neeru. The next one is easy. What are the risks of anti-scarring medication?
Oh, that's a great question. So one of the risks could be that it doesn't heal, so that the drainage is excessive and the pressure becomes too low as well. So there is also a risk of the front window of the eye, called the cornea, becoming dry and developing a lot of what we call ocular surface disease, so an excessive dry eye, essentially, and that's because it can be toxic to the front surface of the eye. So that's why we take measures during the surgery to wash it out, and we only put it on for a minimum amount of time. But there are a couple of the risks of that medication.
Great. The next one is a positive comment. Thank you. That has been very clear, informative, and helpful presentation on a complicated subject. Somebody just wishing us happy Christmas. The next one. You mentioned that certain ethnic groups are at increased risk. I think it's important to clarify which groups, what the risks are, and what the steps can be taken to mitigate these risks.
Yeah, of course. So Afro-Caribbean ethnicities can be prone to more scarring, essentially. So what we find is that they, even if they had scarring of their skin, for example, they just genetically more prone to developing keloid scarring. So when we do the surgery, the key thing we do is we make sure that we use the higher doses of the anti-scarring medication therapy, and also we'd have a lower threshold to do any needling in clinic, for example, or inject any extra anti-scarring medication.
Great, thank you. Great answer. Is the next question, is the Hydrus microstent implant or equivalent an alternative to reduce intraocular pressure?
Yeah, so that's interesting. So there's a whole family of newer stents called MIGS, which are called minimally invasive glaucoma surgeries. So they actually work at that sieve-like structure, the trabecular meshwork, or the structures behind that. So they don't bypass and create a bleb. So the reality is they can reduce the medication that the patient needs and reduce the pressure a little bit, but not as much as a Preserflo and definitely not as much as a trabeculectomy. So they're still found or felt to be the stronger type of procedures which are needed for more advanced glaucoma. But they can definitely work by helping to reduce the number of medications that you need. For example, if you're having a cataract surgery, they can help to reduce the pressure a little bit, but not as much as these two that we've talked about today.
Great, thank you, Neeru. The next one is easy. Is stent and shunt the same?
No. So yeah, so there's hydrostent and iStent are two of the minimally invasive glaucoma surgeries that I was talking about. So they are inserted into the trabecular meshwork, so the sieve structure, rather than out into the subconjunctival space. So they don't create blebs. But I think there's a technical. Some people, it can be a bit confusing because there's so many different words. But yeah, we talk about shunt rather than stent typically.
Great. I think we've time for one or two more questions. The next one is, I've been told that if I need surgery, I would have my cataract done at the same time. How complicated is this?
So it depends what type of surgery they're having. So if they're talking, from my experience, I don't typically do trabeculectomy or microshunt surgery at the same time as cataract surgery, but some people do this in other centers. So I don't know if they're referring to the microshunt or trabeculectomy, perhaps, but is that clear from the question?
No, it's not. I've just read it verbatim.
Okay, yeah. No.
Okay, let's get one more in. After my trab surgery, I needed a cataract. I wasn't expecting this, but the surgeon said this was a common occurrence following eye surgery.
Yeah, so basically because you are entering the eye and there might be some inflammation, or because of the steroid drops that you have to use after trabeculectomy surgery, it can result in a cataract developing. But it's obviously, it is one of the risks of the procedure itself. Sometimes if we can, we try to do the cataract surgery prior to glaucoma surgery, if at all possible. But if there isn't a cataract there, then that is a risk that could develop after cataract surgery itself.
Right.
After trabeculectomy surgery, sorry.
Fantastic. Thank you very much, Neeru. We're nearing the end now. I'd just like to thank Neeru very much for a fantastic presentation and great answers to all those questions. I'd like to wish you all a Merry Christmas as well, and you can order cards on our website if you like. Any unanswered questions, our helpline will be able to answer them. And the helpline number is 01233 648170, or you can email the helpline at Glaucoma UK. We're open Monday to Friday, 9:30 to 5 p.m. We have got another group on glaucoma and cataracts on Monday, the 15th of January, a bit earlier at 6:30. And also on Tuesday, the 13th of February, we've got one covering glaucoma jargon busting. And then in March, we are planning 4 webinars focused on and in around World Glaucoma Week from the 10th to 16th of March. I'm going to launch the last poll in a moment. And when the webinar finishes, we would like you to complete the survey so we can improve our presentations each time. Thank you. I'm launching the poll now. No, wrong one. Bear with me. Okay, I've launched a poll. If you take the time to fill that out, that would be great. Thank you very much, everybody, for spending the evening with us. We hope you've enjoyed the presentation. Really big thank you to Neeru for, I've learned such a lot from that presentation. It was really informative. And thank you very, very much. And thank you to my colleague Helen as well for supporting with Facebook. I hope you all have a really good evening. And don't forget to fill the survey that pops up after the webinar. Thank you very much, everybody, and enjoy the rest of your evening. Good afternoon, Neeru. thank you very much for coming back to answer the outstanding questions from the Preserflo and trabeculectomy presentation you did for us on Tuesday evening. It's really kind of you to come back and answer these few questions. I'll put them to you. So number one, having had 2 successful Preserflo ops, I now have a periantal membrane distorting vision in one eye. The pre-op nurse warned that this may cause retinal detachment if not treated with a vitrectomy. I'm concerned about risks post-op concerning this shunt.
Great. Yeah, so an epiretinal membrane is a sort of cling film type effect that happens on the macula, the central area of the vision at the back of the eye. That can sometimes happen after you've had vein blockages, or it can sometimes happen after surgery as well. And that does cause then visual distortion, unfortunately. To have it removed will help to try and either stabilize the vision from getting worse, or also to sort of try to improve the vision somewhat. But if it goes untreated, it won't. There isn't a risk of developing a retinal detachment as such. It's just more that the vision will deteriorate further. After you've had a Preserflo surgery, I think there is a risk of it failing when you have any subsequent surgery. So the same goes for a trabeculectomy or a Preserflo. For example, if you were then to go on and have a cataract operation, there is a risk that your an original surgery may fail. That is one of the risks that are there. But then obviously it's a matter of having a discussion with the consultant to see how how bad the epiretinal membrane is and how much that's affecting the vision, and consider the factors in terms of the glaucoma shunt as well. So it's quite complex, but it's important to discuss that as a potential risk.
Great. So talk to your consultant about it.
Yeah.
Next one. I had a trabeculectomy in one eye, but this healed over totally within 2 years. I have now had a Preserflo, which has been successful so far. What percentage of patients experience this healing over?
Yeah, great question. So when you have surgery, there's always a risk of scarring, so which we touched upon in the talk. So we used anti-scarring medication to try and reduce that. And by using stronger doses, we found that that's beneficial. The study that I talked about in my talk, what they found was that 29% of patients by year 2 didn't have enough pressure lowering, so they hadn't reduced enough. The way we measure that is if we get a 20% reduction in pressure, we think that that's a good outcome. So there were 29% that didn't have the pressure reduced by that proportion after having had the surgery. And then 10% of the total patients had to go on to have further glaucoma surgery to stabilize their glaucoma. So there is that risk with Preserflo surgery that it may fail. And it's also interesting that it worked in one eye and not the other. So it just shows that even in the same person with the same potential healing mechanisms, you can still have a different outcome between the two. So it's a matter of monitoring it in terms of the pressure control, potentially adding in further medications if needed. And if not, then you might need to go on to have other types of glaucoma surgery.
Great answer. Thank you. Everybody's an individual in this case, by the sounds of it. Okay, the next one, Neeru, is what is the difference between Paul Brevad, spelt Brevadt, we're not sure if that's the correct spelling, and Preserflo?
Yeah, so a Paul tube, and it's called Baerveldt, so it's Baerveldt tube, and there's also a tube called an Ahmed tube. So they essentially have a tube which is then attached to a plate at the back. So rather than the Preserflo being a small little tube, the tube sizes are slightly larger, and they have this plastic type material plate at the back of it, which is inserted in the eye. So they get the pressure down quite a bit lower, so similar to trabeculectomy. Trabeculectomy is still the procedure that can get the pressure the lowest, and we usually use that in cases where we think that there's a risk that the trabeculectomy might fail. So, for example, if they have a lot of inflammation in their eye, or if they've had a previous trabeculectomy and that's not worked and they need something more, then we might go on to do that tube surgery. And that's because by leaving these devices in, they have an area where it'll help to reduce the risk of scarring over that region. But again, there is always a risk of any potential tube surgery also scarring. So that's something that you have to be mindful of.
Great, thank you. The next one's a short one. Are Preserflo and eye stent the same?
Yeah, so they're not actually, because the Preserflo is a tube that goes from within the front chamber out beneath the conjunctiva and creates that bleb similar to a trabeculectomy. Whereas a eye stent is a type of MIG surgery. So that's where this little metallic device is implanted into the trabecular meshwork, the sieve-like structure, to provide an alternative little hole for the fluid to travel through. So that comes into the category of MIG surgery, whereas Preserflo isn't really classified as one of those. In fact, one of the names that's often coined is MIBS surgery. So that's minimally invasive bleb surgery. So it comes under that subcategory.
Right, great, thank you. The next one, Neeru, is how long does the trabeculectomy last?
Yeah, so because we've been doing it for a lot longer, as I alluded to, from 1970 onwards, we have had some studies that have shown that they can still be working at 20 to 30 years later. So, for example, one project which looked at the results from Cambridge found that 57% were still working at 20 years, which is great. So, but there were 88% that were still working, but they needed extra drops. So one way we think about how well the surgery is working is if you need to start adding in drops again to get that pressure a bit lower. We still feel that the surgery is working, but we need that little bit of extra assistance. Whereas with the ideal would be that the trabeculectomy is done, you come off all of your drops, and that continues to work lifelong. But we do realize that that's about 50 to 60% of cases will have that long-term success. Sometimes you need to have little needling procedures to kind of help it further on along the way as well.
Great, thank you very much. The next question, Neeru, can prolonged use of glaucoma eye drops cause excessive dry eyes?
Yeah, so it's interesting because obviously it feels a bit counterintuitive that you're putting a drop in your eye, and why would it feel dry? But we do find that the medications that are used can cause the eyes to become drier sometimes. Sometimes it can be the preservatives within the medication that can make the eyes a little bit more dry also. So there's no harm in putting in dry eye drops between glaucoma drops, so within the day. But what I would advise is not to put it in directly after having used your glaucoma drop therapy, because you don't want it to wash out that medication. So if you find that you're having a lot of dryness or irritation, it's best to mention it to your consultant to just or your clinician to make sure that there's no dry changes on the surface of the eye. They can then examine it and see if that's the case. When you talk about dryness, the symptoms that you normally get is a feeling of grittiness in the eye, like or a little bit of heaviness. And you might also find that the eyes water and stream a lot, and that's to compensate for the fact that the front surface of the eye is becoming dry.
Great, thank you. So the next question, Neeru, is what's the issue with low pressure, please?
Yeah, so and that's really important. I don't think I touched on that enough during my talk. We want to obviously get the pressure down, but if the pressure becomes too low, the best way to think of it, and it sounds a bit crude in a sense, but if you think of the eyes obviously as the ball shape that it is, like a football, which doesn't have enough air in it. So the worry is that the back of the eye, the inside layers of the eye might become a bit softer, and that can actually affect the vision. So we want to get the pressure down low enough that it's still maintaining that nice tension within the eye itself, because if it becomes too soft, it can then start to affect your vision also at the back of the eye.
Great. The next one touches on pressure again. I have normal pressure glaucoma with pressures averaging 16 to 18. In 2010, I had a trabeculectomy on one eye, which was needled 1 month later. Pressure in that eye was a consistent 8 or 9 for 8 years when the pressure dropped to 4. My eye now averages 5 or 6. Is there any point when the pressure is too low, and what can be done to help my eye, please?
Yeah, so with the pressure coming down, We talk about numerically the pressure being too low, and we usually use a pressure of about 5 as the numerical number below which we are worried if the pressure is too low. But the reality is, we find that some people can have a pressure about 4 or 5, and their eyes are perfectly healthy. So, especially with someone with normal pressure glaucoma, obviously they're already starting at a pressure that seems to be within normal. So we do need to get it down from that. So even though the numbers may be low, your eye may now be able to tolerate that, may have great vision and have no problems at all. If the pressure became too low that we're worried about the back of the eye, for example, being softer, or if it's affecting the vision, there are measures that can be done to try and help pick up that pressure. One of them includes putting a suture over the surgical site to sort of close it down. So instead of allowing that flap to be open and allow fluid to drain, by putting this suture over it, it actually helps to close it down, so that there's not enough fluid draining out, and that will pick up the pressure. There are other types of procedures that can be done as well, but it's important to have that examination and for the clinician to determine whether the eye is too soft and whether there are any changes at the back of the eye. So it's important to speak to them about that, and obviously they can advise you further.
Fantastic. Thank you very much. Next one. I had laser treatment for diabetic macular edema on my right eye. I have advanced glaucoma in both my eyes. My glaucoma consultant suggested to have Preserflo once it is authorized by the local NHS to reduce my eye pressure. I am 70 years old. I wonder what would that undo what laser treatment did for my DMO. My DMO is currently under control as far as I'm aware.
Yeah, that's it's really important. So anyone who has diabetic retinopathy or any diabetic changes at the back of their eye, any type of surgery, there is a risk that it could cause specifically diabetic macular edema to come a little bit worse. So that includes cataract surgery, for example, or if you were to have a Preserflo surgery. And the reason that is because the surgery itself will just induce a little bit more inflammation. The blood vessels may become a little bit leakier in a sense, and that might cause the fluid to get a little bit worse. So it's important that it's monitored regularly for those patients after having had the procedure. The reality is that if the pressure is not low enough and we left that, if you wanted to avoid that happening with the diabetic changes, but the pressure continued to run high, then that could affect the vision as well. So I know it can be a bit of a daunting prospect to do something that might make one condition worse, but the key thing is that you're monitored afterwards. And we can also then give extra drops to reduce inflammation. So they're called non-steroidal anti-inflammatory drops, similar to the ibuprofen family. There are those kind of drops that can be given at the same time as cataract surgery or Preserflo surgery to kind of avoid any of that leakiness from developing. But the key thing is monitoring. And if you need to have further treatment for the diabetic macular edema, that can be done as well. It won't change the laser that's been done in the past, but there are other options of treatment afterwards if it did get worse.
Right. Thank you. Are there any alternative laser surgeries or MIGs to a Preserflo, which I have been advised to have?
Yeah, so there are lots of different MIGS type of surgeries, and there's also, in terms of laser surgeries, there's either SLT laser, which is selective laser trabeculoplasty, which helps to clear away some of the debris within the trabecular meshwork. The reality is it can be a very individual case. So, for example, if the glaucoma is more advanced, MIG surgery or SLT surgery may not be felt to be the most appropriate thing at that time for that patient. So there are different options available. The MIG surgeries will usually get you off 1 or 2 drops and get the pressure down somewhat, but it won't necessarily get the pressure down as low as potentially a trabeculectomy or a Preserflo surgery either. So it's important to have that discussion depending on how severe your glaucoma is with your clinician.
Great. Okay. I think we're on to the last one now, Neeru. Thank you. And it touches on pressure again. Low pressure was mentioned as a risk, but what the risks were not covered.
Yes, yeah. So that's what I've So that's what I was talking about earlier. So with the pressure being too low, there's a risk that the back of the eye could get affected in terms of kind of the area where the vision is seen from, and so that is the worry that you have. But it can be treated if it's too low as well.
Great. Okay, that brings us to the end of all the questions. Thank you ever so much, Neeru, for coming back to answer the outstanding questions. We really do appreciate it.